Hey, DNA. I'm Kate Wilson, and this is All Access DNA. Before we get into today's episode, we need your help. Please take a moment to leave us a review and rating on your preferred podcast platform. This helps other folks find the show. And if you have an idea for an upcoming episode, reach out to us at allaccessdna@gmail.com. I had the absolute pleasure of talking to Sarah Scollon for this episode in honor of Childhood Cancer Awareness Month. Sarah is an assistant professor in Texas who works in both clinical and research roles in the field of pediatric oncology. She has a long-standing dedication to the care of children and families affected by cancer. We discuss why genetic testing may be indicated, the psychosocial needs of kids who have been diagnosed with cancer, and the evolving guidelines for managing childhood cancer. Let's get started. Hi, Sarah. Thank you so much for being on the show today.
Really happy to be here, especially in September, which, as you know, is Childhood Cancer Awareness Month. So an exciting time just to talk about this topic.
Yeah, and we're thrilled to have you on being such an expert in this space. I was wondering if you could tell us a bit about the children that have cancer and about how many do you think have cancer associated with a genetic mutation that might increase the risk for inherited cancer?
Yeah, we have actually learned a lot about that question over really the last 15 years. And we're part of some of the genomic studies that contributed to that knowledge. But there have been several studies, both at institutions, national, international levels, that have done genomic sequencing in different populations of children with cancer. And out of that, we've learned that about 8 to 18% of kids do have what we call likely pathogenic or pathogenic mutation in a gene that raises your risk for childhood cancer. Of course, I think it's important for families who have children with cancer to know in many cases it is something that happened by chance, but identifying those kids who are at risk because of a hereditary reason is obviously what I've made my career about, to be able to identify and really help care for them the best that we can.
So what you're saying is that many kids will have cancer and it might be due to random chance, sporadic changes, but there is this percentage, I think you said up to 18%, where there is something that might be in the family or passed along that's increasing the risk for cancer. Got it. And I know that in pediatric oncology, there is a lot of tumor testing. I mean, we see that in adults as well, but particularly in pediatric oncology, doing genetic testing on the tumor.
Mhm.
But that may be different than doing what we call germline or testing on the blood that looks at inherited forms. So, what are the differences between tumor and germline testing?
Great question, and can be a confusing topic, especially for families who are going through the testing. And the two have their individual purposes. Although the better we're getting at these technologies, we are seeing some overlap, and I can kind of explain where that is. But with tumor testing, what we're really focused on are the mutations that happened in the tumor itself. So, what might be driving that cancer to happen? It's not surprising for us to find mutations in a tumor. At its core, when a cancer happens, it's often because a genetic change has happened somewhere in a cell that has made that cell lose control, and then cell after cell lose control until they develop into a tumor. So, with tumor testing, what we're looking at is the genetics of the tumor itself, really to help us with three primary goals. And that's one, it can help us with diagnosis, it can help us learn a little bit more about the tumor itself, can help us sometimes with prognosis. So, understanding is that a tumor type that might behave more aggressively or less aggressively. And then also, one of the things we're really working towards is could we find a treatment, a targeted treatment towards a mutation within the tumor or the way that tumor behaves that could help make that treatment more easy. On the other side of that is germline testing, and that's really where the space I live in. So, germline testing, we're thinking of all the cells in our body. And there's different ways we can get at that information. Probably moving forward, I'll just use the blood when I'm talking about it, but we use blood, saliva, buccal samples sometimes. But these samples can give us an idea of what's going on in all the cells of our body or the cells that we were born with. So when we're doing germline testing, what we're really looking for there are a set of genes whose job it is to protect us from developing tumors. And if one of those genes isn't working properly because of a genetic change, a person can lose that protection, and over their lifetime, they can have an increased risk of developing tumors. So by doing that testing, we're working to identify those people or those children in this scenario who have an increased chance across their lifetime of developing tumors, so we can watch them more carefully to try to catch those cancers or try to catch those cancers as early as possible.
So the tumor testing would be done on somebody that has a diagnosis of cancer for a few different reasons, but one of the main being trying to figure out if there's a treatment available specifically for that tumor type. And then the germline is thinking about the current cancer, but also potential future cancers or trying to prevent those.
Exactly. We have seen, I mentioned the overlap. The better our technologies have gotten, especially with tumor testing, we're doing more and more molecular testing of tumors. Sometimes a family or a child may end up in our clinic because we may see something in the tumor that raises concern that they have a predisposition syndrome or a hereditary cause of their cancer. So, for that reason, they may be referred to us with a tumor report that might be suggestive of that. So, we'll then do testing on the germline to try to answer that question. And then in some institutions like our own, at some points through our research studies, what we've tried to do is actually pair that testing. What we do, tumor germline pair testing, so we can try to answer that question at the same time. Most of that has been done in research context because obviously a lot of resources go into being able to do that. But that is another approach that can allow us to simultaneously gather that information.
So you might see kids that have come in because something raises a flag on the tumor testing, but you might also see kids that have come in that have been identified for another reason to be a candidate potentially for germline testing.
Exactly.
Okay. And I mean, in your experience, are these children that have been diagnosed with cancer, are all of them getting tumor testing or are all of them getting germline testing? Like who should be tested?
Yeah, and that's an evolving area, and I think we're trying to still learn the best answer to that question. Historically, we've relied on kind of what I consider the red flag system. So these red flags of if it's a child with cancer, it might be a specific cancer type that we know has a strong association with the hereditary condition. We often refer to those as automatic referrals. So if you have that diagnosis, you would come to see us for germline testing. We also can see children with cancer who have a family history of cancer. Maybe they have other clinical features that raise concern. Sometimes we see children without cancer come to us. So a condition may have been identified in their family, or maybe they have physical features that are suggestive of one of these syndromes. So, for a variety of reasons, a red flag has been raised that we teach community members, pediatricians about to come to see us. What we've learned through some of these genomic studies, though, is just that referral system alone. Not every child that we have identified through genomic studies would have necessarily been picked up through the referral system. So I think that's one thing moving forward that we're really trying to figure out: how do we best pick up all children who have these predisposition syndromes? And some of that looks like, do we need to refine the way that we're doing referrals, make that more systematic? Other things that we're considering is, should this be universal? Should we move towards a world where we consider genetic testing, germline genetic testing, or in some cases, tumor on all kids who are diagnosed with cancer to gather that information? And I think we're still learning what that might
Mhm.
look like, but I think that's a direction the community might be moving forward.
And that's helpful to know. One of the things that I wonder that patients have asked is, what does it change? Like if I know that my child does have this germline mutation or does have a cancer predisposition syndrome, how does that change what we're going to do or treat them?
And in many cases, it changes a lot, and that's why I think this work is really important. And we have spent a lot of times learning about the testing technologies, how to identify these kids, and I think we're moving into an era now of what next for these families. But for many, when we make a diagnosis, what that means is there may be a set of surveillance guidelines, ways that we're going to follow that child more carefully, specific to the gene, specific to the tumors that they may be at risk for. So when we make one of those diagnoses, we'll meet with the family and we lay out that plan. And that plan has really evolved because of a lot of work that the community has done. One of the major things that happened was the development of the Pediatric Oncology series. So this was, for many years, for conditions we've known about for a very long time. We had good surveillance plans, things in place that we did to take care of these kids. But for some of the predisposition syndromes, we didn't have those plans in place, at least evidence-based. And so this was a workshop, originally has always been sponsored by the AACR, the American Association of Cancer Research, but we originally came together an international workshop. Several of us from Texas Children's joined that workshop, and it included oncologists, geneticists, genetic counselors, people who are involved in, experts in the imaging and things that we do to come up with a set of consensus recommendations for each of these syndromes that were published. And we just recently redid these. And so the
Mm.
last end of these new publications are coming out. But because we had next steps, we had a plan that, again, was evidence based, brought together by experts. It really can give parents a next step, a step forward. And I think we're very lucky of a model here at Texas Children's that we have
Mhm.
the next step in the form of what we call the Cancer Prevention and Screening Clinic. And more of these clinics are coming up at pediatric centers. But we have had, this probably going on 14, 15 years now, where if a child has a diagnosis in our clinic, we then have the next step. We have the clinic, the team to send them to where they're followed over time. And that can look like a lot of different things for a child. It may be doing routine scans, in
Mhm.
some cases doing things like whole body MRI, blood work, and each of those plans are individualized based on the condition and what we need to look for. So from a practical standpoint, that's the clinical care. The other piece we need to think about them is the psychosocial part of it too,
Mhm.
because this is long-term screening for these families. It is living with risk. And so that is another component of some of the research that we're doing and that I'm actively involved in right now is once we make these diagnoses following these families to learn more about how do they access this care that they need because not everyone has a Texas Children's in their backyard
Mhm.
and what that looks like for families and also how do we need to take care of them from a psychosocial perspective too with the anxiety and things that can come up with every time they face one of these scans.
Yeah, because I would imagine that I mean, it's already gotta be a pretty scary time, particularly for the parents who generally know what's going on, and then for the kid who may or may not quite understand all the things that are happening, but that as they move forward, having this additional workup or these additional scans down the road, maybe after the immediate treatment.
Yeah, yeah. And what we really work to do is, especially when a child is going through the treatment itself, the team with our cancer prevention and screening clinic will work very closely with the oncologist. So there's the flow just kind of continues for the family through their treatment, and the additional things that need to be done are being done. And then, once that treatment's over, they can transition and really move into
Mhm.
the surveillance care itself, but it's lifelong screening. So
Mhm.
we actually have worked with right now nationally through the NCI. There's a study called the Molecular Characterization Initiative where kids across the country are getting this large scale germline and tumor sequencing. So we are doing research involving a cohort called the Origin cohort, where we're going to actually try to follow these families to find out these questions. What does access to care look like? What is the healthcare utilization? What are they doing with this information? And also some of the psychosocial outcomes of that. So working with the NCI, COG, I'm lucky to work with Dr. Philip Lupo, who is an epidemiologist now at Emory, that we're
Mhm.
working to understand that population a little better.
Yeah, and it's so interesting because this is medicine and treatment that's sort of happening in real time, right? Because we
Yes.
didn't have some of these things 10, 15, 20 years ago. So, like you said, there's studies coming out. There are large multidisciplinary groups that are working to try to further define guidelines and kind of next steps because we're in the middle of learning this and creating, this path forward for these patients.
Yeah. And it's a work in progress. And that's why we just
Mhm.
revisited the guidelines. And I think we'll continue to do so because we really want to optimize, the care that we're giving them the best we can so that we can catch a cancer as early as possible, but without putting families through extra treatments or screenings that they may not need. So really just
Mhm.
trying to find that balance to optimize the care that we give these families.
Mhm. In all your time working with these families and then again with patients, some who might be very young, what has the attitude been towards genetic testing? I don't know how it's discussed or how it's handled with these families and patients.
I generally speaking, I think it's well received. And when you find a family in the situation where their child's just been diagnosed with a cancer, most of them want to do anything possible to try to,
Mhm.
better the situation, to do the best they can for their child. Questions often quickly come up about other kids in the family. I find parents care about themselves last, but the whole family unit is potentially affected. So uptake of this type of testing tends to be pretty high in my experience. We have families who decline it, and those are important families to have these conversations. The reason why we should have these conversations. If for those who decline it, sometimes it's simply like in the moment, they are just too overwhelmed with what they're dealing with. And those families may come back to us down the road when things have settled down a little bit to do the testing later. And for some families, it's not information they want. They're not ready to have the information about genetic risk. It might have privacy concerns, that type of thing. And that's what informed consent is about.
Yeah, very, very good point. And I think, some folks misconstrue going into talking to somebody like yourself or at their clinic doesn't necessarily mean that this test is going to happen or these are the things. But like you said, it's an informed consent. So it's going over the options and what
Exactly.
it involves.
We just want families to understand everything available to them and walk them through a personal decision.
How does it differ, this kind of like making a decision,
Mhm.
like this informed consent, when it's a young child versus somebody who's an adolescent, perhaps, and may have more thoughts and a say in their
Yeah,
care?
good question. And go back to the concept of what ends up being developmentally appropriate to some degree. We have done some research in our what we call AYA, so adolescent young adult populations, that show that they do want to be part of these conversations. They want to be part of what we call shared decision making with their families.
Mhm,
I think that the in the context of going through cancer treatment and just having cancer itself, there is a level of loss of control there. This
mhm,
conversation gives them a place where they could have some control and say. And so we very much involve them in the conversation. Some more kind of in the young adults, those who are really involved in the conversation. Some are more and less interested in it. So, some kind of defer to their parents. Some are really involved and we have a conversation about what this looks like and what it's going to mean to them. And some of our families, we diagnose babies, we diagnose
mm,
toddlers, children who
mhm,
are too young to necessarily be involved in the conversation at the time. And for those families, what we try to do is offer genetic counseling later. So as that individual gets older and starts to have questions, whether it's when they're a teenager or whether they're approaching kind of that age where they're aging out of the pediatric system, that they come back for genetic counseling so that they can
mhm,
have those questions answered and understand their diagnosis at that time. But I think I always, for any child who is, at the age where they can give assent, which is kind of we ask parents for consent. And under the
mhm.
age of 18, we work towards assent for the child. We involve them in the conversation because it's very important that they understand, what this can mean for them and what it means moving forward.
And like you said, gauge it kind of on developmentally appropriate education, language, kind of where they're at as well.
Exactly. Exactly. You're going to talk about it much differently with, an 8-year-old than you're going to with a 14-year-old. And so,
Right.
but to me, it's important in those conversations that at the level that they can understand, that they understand, you know, an aspect of what we're doing.
One of the aspects I see mentioned a lot in pediatric oncology settings is cascade testing.
Mhm.
And so, as you said, uh, that it can impact other family members, these germline genetic test results, right? Because a family may share their DNA, if they're blood relatives. So, what exactly is cascade testing, and how does this kind of come into play after a child's been diagnosed with a cancer predisposition syndrome?
It is, in the disclosure sessions that we have, it is one of the components. Disclosure when we're sitting down to share those results initially, it is included in that conversation and what it means. Sometimes a child is the first person in the family. So it may have
Mhm,
just, in that sperm or egg that made the child a change happen. But many times we can see, and it sort of depends on the conditions, but we see that it is passed down from a parent. Most of the conditions that we see in our clinic are autosomal dominant, meaning it just needs to come from one parent. More rarely, we can see the type where a change gets passed down from both parents who are carriers. For that reason, once a child has the diagnosis, you now have parents and siblings who are potentially at risk to also
mhm,
have the same condition. So we actually often will see the whole family, immediate family, to offer testing to the parents and to the siblings for the same change. And that's cascade testing. It is once we identify the specific change in one child, we then can look for that same change in everybody else. And it can be a yes or no answer. And if we do identify someone else in the family who's positive, then we set them on the same trajectory to, if they're children, to the cancer prevention and screening clinic here, and if they're adults, to get them set up with an adult center nearby. And when you think about the whole family tree, if we identify a parent, we move on to aunts and uncles. Now we will refer
Mm.
them out to other, depending on age, we'll certainly see the children here, but you just begin to work out through the family. So that first child, as unfortunate as the circumstances are of having cancer, are often, sometimes the person who ends up informing the rest of the family and putting them in a place where that they can take some steps to best take care of themselves and try to watch out for cancers that can occur.
So it could be really beneficial for other family members to learn this information because then they could also take steps to find out if they have something, the same mutation.
Very much so, yeah. And I think that is when we go back to what you asked earlier about uptake of the testing. I think it can be a driving force because they have just gone through a cancer diagnosis with one child, or maybe it's a parent who's gone through it. Sometimes we'll see kids after their parents were diagnosed, and so to then be able to put into action the ability before a cancer happens to begin screening and catch something early really can empower a family, I think.
How do you explain things like a cancer predisposition syndrome or perhaps even testing of other family members to a kiddo? Because I would imagine with some kids, they may have a lot of questions. Some kids may also be a little bit nervous hearing that, oh, now my brother or sister has to potentially undergo testing and they might have concerns about them. So how do you have these discussions?
Again, developmentally appropriate.
Yeah.
But, one thing I have found becomes very important in this context, whether it is the child who has just faced a cancer, or if it's a sibling of a child who just watched their brother or sister go through cancer, or a child whose parent, just went through cancer,
Hmm.
to emphasize that this is not a cancer test. That can get confusing for kids
Hmm.
to have seen someone else go through this, and now you're getting tested for something that feels very close to this. Their first instinct is, does this mean I have cancer? So really helping to frame that this isn't a test for cancer. This is a test to see if you are at a higher chance to develop cancer across your life, and for us to be able to watch you more carefully. And what that means for a child can vary. At a young age, is a conversation about, this might mean you're going to need to see a doctor more often than usual, and you might have to have scans. And with an older child, you can be a bit more detailed.
Hmm.
But I think any child who has met with me has heard my analogy, because I really do explain it as it is another tool in your toolbox to take care of yourself.
Hmm.
And in the moment of getting one of these diagnoses, it may not feel that way. But at the end of the day, many of us are probably at risk for something in our lifetime. And we've now been able to give a person or a family information for what they can actively do to keep themselves as healthy as possible in the circumstances. So I do compare it. That's what I say to everybody. You now have another
Hmm.
toolbox in your toolkit to take care of yourself, and
Hmm.
we're going to help you do that. So
Yeah,
it's
I would
great.
say it's very, very similar to, I think, adult clinics where I worked, and I think the call out is, "This test is not a test for cancer."
Yes,
And I think there's some folks that don't think you necessarily need to repeat that even to adults, and I'm like, I think you do, just because, again, it can be very nerve-wracking and a lot of emotions, and so just making clear what we're looking for.
agree.
One thing I did wanna ask, kind of in thinking about talking about, like, advancements of genetic testing
Mhm.
and being able to find out information. We're learning so much more, we have more capabilities, so is there a chance that you would test a kiddo today and that they would need germline genetic testing in the future, whether something was found or not found? Like, is there a need to do additional testing or repeat testing in the future?
It's a really good question, and I think it depends on the setting a bit. So I'll start with the ones that typically know, So if we have tested for a known family mutation and we know that mutation, we know what we're looking for, and a child comes back and they're negative, then for that condition, there's really no reason
Mhm.
to move forward with, any further testing, because our genes themselves don't change. Now, we do explain, we tested for this mutation and that, this specific syndrome. It doesn't rule out everything, cancer or every health condition out there, but for the purposes of that test, it doesn't need to be repeated. If someone's positive, then that doesn't need to be repeated. we have not, we found the mutation. I guess one could argue when we get into variant classification, that some of that can change over time. The context when we might talk about having people revisit it is if, particularly if it's a tumor, we know that we're continuing to learn about the genetics of,
Mhm.
that it is fine to, one, if something changes in the family, if something changes in the child's healthcare, to come back with that new information to us to see if there's anything new we might consider. When they're planning families, they might want to revisit the test to see if there's updated information. And then there's some things that it's juvenile polyposis, so more of a polyposis syndrome. But we know in our pediatric population, and we're trying to look at this nationally, most of our kids test negative for the two
Mhm.
genes most strongly associated with the condition. And so for those families, we do talk about research or coming back in a few years because we know our knowledge isn't there yet, and is a growing area where we might more proactively have them come back. So I think, yes, the technologies are changing. We will get a call from a family who maybe saw us 10 years ago. We'll take a look at what technology was used at the time. And sometimes we'll say, yeah, let's redo it with the newer technology, or with, obviously genomes and exomes. We don't use those as much in cancer, but they're available. So there are situations where we might redo a test, but the genes themselves don't change. It's more our ability to analyze them, I guess.
So it'd probably be good advice for somebody who's been through this, or at least initially had a visit with somebody like yourself, that they kind of check back in every so often. Like you said, there might be families that call a few years later, either because they've had a change in their family history, or they just want to see, is this something we should be thinking about?
Yeah, I think that's a general rule of thumb. And we usually, when we go over what a negative test result means, because that, depending on the clinical context and the
Mhm.
scenarios I just talked about, can mean different things. But we try to give that guidance, during those discussions. But I always welcome a call from a family. Either way, I'm happy to take a call and take a look at, if there's anything new, if they have any new questions. And it's also just a good chance for me to see how they've been doing,
Yeah.
because we do remember these families.
Yeah. Yeah. If somebody right now has questions, like say they're a parent and they have a child that's either going through treatment or maybe was diagnosed a few years ago and is, been in remission. If they have questions about genetic counseling or testing related to a cancer predisposition syndrome, where could they go to find more information?
It's a good question. I'd probably start with your pediatrician, because your
Mhm.
pediatrician may know what clinics are available, what genetics resources are available. The National Society of Genetic Counselors, Find a Genetic Counselor, is a place I'll sometimes go to help families who might be in a different place to identify someone in their area. And, because, many of these centers tend to be in more kind of large metropolitan areas or in large academic centers. So those are good places if you're looking to potentially start. The other area is if you have a known condition in the family, often those associations. So for instance, I sit on the advisory board, the genetic counseling advisory board for the Leukemia Association, and they have a place, if you have that diagnosis in your family, that you can look and find providers near you. So if there is a specific condition, you might try a foundation that might be tied to them to find resources. And you can always call one of our places, and see if we can help give guidance. But I would probably just try to start with your provider, your pediatrician, because they may know the network most immediate. And if they
Mm.
don't know, NSGC is a good place to look for genetic counseling.
Yeah, and we'll provide a link to the Find a Genetic Counselor tool as well, so that way if people are looking for that, they can look up the website. Well, Sarah, I appreciate you taking the time. Is there anything else that we haven't covered that you think is important, or anything that you really in particular want folks to remember about the conversation today?
No, I mean, I think we're kind of launching into just a new era of excitement in this
Mhm.
area, because, like I said, we've spent the last 15 years really doing these genomic studies, really understanding the landscape, and also developing the guidelines to take care of the families. And I think the path forward now are the things, I mentioned. How do we take care of these families long term and longitudinally? And we're thinking about that. How do we provide them the access to care that they need? We're even talking about ways to find them earlier, to
Mhm.
studies looking at utilizing newborn screening potentially, so the heel prick for babies when they're born. So I think, we really are trying to think about how best to optimize identifying, finding people as early as possible, putting these management plans into place, and we might even get to where we're continuing to look, if you have one of these diagnoses, what could it be a treatment for you too? So I think that it is an exciting time in the field. And I do, especially in the context of Childhood Cancer Awareness Month, just like to thank all the families who have been involved in the research that has gotten us to this point, because we stand on their shoulders for allowing us to join them on their journeys to begin to find these answers and just make the future hopefully better for their families, but also better for future families. And that's why I love the work.
Yeah, I could tell you're very, very passionate about it. And like you said, it's an exciting time to be able to see what's happened in the past, the research, what things have been building to, and know that we're right on that edge of where we've been trying to get to for some time.
Yes, I think we have a bright future ahead of us.
Well, thank you so much, Sarah. I appreciate you being on the show today.
No problem. Happy to be here.
For more information about this episode, visit allaccessdna.podbean.com, where you can also stream all episodes of the show. This link is also in the show notes for easy access. Any inquiries on the podcast can be sent to allaccessdna@gmail.com. Check out our Patreon at patreon.com/allaccessdna and consider donating to get bonus content, submit questions for our guests, and connect with other genetic curious individuals. Note that this podcast is for entertainment and education and is not intended to be a substitute for professional medical advice. Please consult your physician with any questions you may have regarding your health. Please rate and review the podcast on Apple, Spotify, or wherever you listen. This helps other people like you discover the show. All Access DNA is hosted, produced, and edited by Kate Wilson. The logo design is by Designs by NKJ. Thanks for listening, and join us next time.